What's up guys, to another video. Today we're gonna cover OB/GYN. We're gonna do a super cram session. I'm gonna try and cover as much as we can in the time we have here. This is intended to be basically a last minute overview to go over all the must know points for your OB/GYN for either step 2 CK or for your shelf. Hopefully this is helpful. So let's start. First, we're gonna cover obstetrics. So postpartum hemorrhage is defined as over 500 milliliters vaginal delivery of bleeding or over 1 liter from C-section. And the most common cause is due to uterine atony, and that's from basically when you're in labor, your uterus is contracting a lot, and after delivery of the baby, the uterus is weak, and then the spiral arteries, because of the decreased tone of the uterus, it can't contract fast enough, and the contraction of the uterus actually clamps the spiral arteries. So when you have basically a flaccid, weak uterus, those spiral arteries are just open and dilated, and they're basically just hemorrhaging. And so the main thing I want you to look for in a vignette is when they say that the uterus is above the umbilicus, because that basically means that it's foggy and big, and when a uterus contracts, it gets smaller and it should be below the level of umbilicus. So then the first step is to diagnose it, but then the next is to know what to do. And the first line treatment for that is uterine massage. So you want to massage the uterus and help get it to a smaller size. And then afterwards, you can also administer oxytocin if needed. There's another type of common cause of postpartum hemorrhage, and that is due to retained placenta. In a vignette, usually you'll notice that they'll talk about the placenta coming out, that it may have looked like an incomplete placenta, and it doesn't look, clean. And so they might talk about on ultrasound that you see an uneven endometrial lining. So that unevenness is basically describing that there's retained placenta in the uterus, which is causing that uneven lining. And then what you want to do is a D&C to remove that retained placenta. If it's not uterine atony or retained placenta, then another common one is lacerations. And so usually in a laceration vignette, it's associated with forceps delivery. So when you put the instrument up the vagina or cervix, it's at risk for laceration. Of course, in that vignette, then the uterus will be below the umbilicus, and then ultrasound will show even endometrial lining. So that kind of rules everything out. And if there's forceps involved, then it's most likely laceration. And then to treat that, you would do a pelvic examination and inspect for the laceration and then suture it closed. So then what I wanted to talk about next is active phase of delivery. So you have your latent phase, which is from 0 to 6 centimeters cervical dilation, and then 6 centimeters on to 10 centimeters, that is called active phase. Why that's important is because you need to know a term called arrest of active phase. So that's defined as 4 hours of adequate contractions or 6 hours of inadequate contractions. So then you need to know what is adequate contractions. So adequate contractions is loosely every 2 to 3 minutes you have contractions, or if you want a precise definition, it's greater than 200 Montevideo units in 10 minutes. So a Montevideo unit is basically the sum of the uterus pressure changes above baseline with each contraction in 10 minutes. So if that adds up to over 200, then you have adequate contraction. The cervix is no longer dilating. That's called arrest of active phase. And then you want to do a C-section. After 10 centimeters, when you have maximum dilatation of the cervix till delivery, if that takes longer than 3 hours, that's called arrest of descent. And usually the number one cause of that is due to cephalopelvic disproportion, which basically means that the baby's head is too big to fit through mom's pelvis, and you want to treat that with a C-section. So uterus rupture, the vignette will usually talk about how mom was in labor, all of a sudden she had intense pain and the baby's head was originally at, say, the 0 station, and now it's at the -3 station. That's basically pathognomonic for uterine rupture. And usually they'll also describe that it's difficult to palpate to find where the baby is in the uterus because the baby has most likely is now slipped out of the uterus and in the peritoneal cavity. So when that happens, obviously you want to go into a C-section. Obviously you want to do a laparotomy and then take the baby out. And then prolapsed cord, which is basically the umbilical cord, has prolapsed through the cervix. And obviously since the umbilical cord is in the way of the path of descent, it's too dangerous to deliver vaginally, so you want to deliver through C-section. So when we talk about fetal tachycardia, so basically heart rate that's normal for a fetus is between 110 to 160. So anything faster than that, what do you think would be the cause of that? So fetal tachycardia, the cause is generally maternal fever. So if the baby's heart rate is over 170, you should suspect maternal fever. Common causes of maternal fever would be infectious causes, right? So like pyelonephritis, chorioamnionitis, or endometritis, which I'll talk about later. So tachysystole is defined as 5+ uterine contractions every 10 minutes. So this is too much contractions, and this can cause fetal bradycardia, which isn't good for the baby. And so you want to treat this with a tocolytic, and the first line tocolytic is terbutaline, which is a beta-2 agonist. Don't forget that tocolytics, their number one adverse effect is pulmonary edema. So beta thalassemia, what would be a marker that would help you distinguish beta thalassemia from other microcytic anemias? It has elevated hemoglobin A2, so that's a sign to look out for. So remember that there's certain changes that happen with pregnancy that are normal, and so usually mom will have elevated cardiac output, elevated GFR, and because of the elevated GFR, she'll also have glucosuria, which is perfectly normal. She'll also have metabolic alkalosis, which is expected to be normal too because she has to breathe for 2 people. She'll have increased tidal volume, and this will cause her to expire PCO2 more, so her PCO2 is usually lower than average. If it's above 40, that's usually not a normal sign. So if you see alkalosis in a pregnant woman, don't panic, it's pretty physiologic. Also, remember that basically when mom's pregnant, she has increased plasma volume too, and this dilutes the red blood cells, and that's physiologic anemia of pregnancy. So it's expected for mom to have anemia during pregnancy as well. Shoulder dystocia is basically when the anterior shoulder gets stuck behind mom's pubic bone and the shoulder kind of gets locked in place. So the first thing you want to do before you concede to the diagnosis of arrest of descent, where it's impossible to get the baby out vaginally, is you want to try something called the McRoberts maneuver, which is hyperflexion of the hips, and this should hopefully pop the shoulder out. And that's the first thing you want to do. So remember, prenatal risk factors for shoulder dystocia for a mom is if she's had a prior episode of shoulder dystocia, if the baby's macrosomic, and usually macrosomia is caused by gestational diabetes. And remember, gestational diabetes, there's a difference between that and pregestational diabetes, which is the presence of diabetes before week 20 is called pregestational diabetes. And after week 20 diagnosis is gestational, and they're different because they have different complications associated with them. Pregestational diabetes is much more dangerous. It's associated with congenital malformations and cardiac defects, whereas gestational diabetes is more associated with preterm labor, macrosomia, shoulder dystocia, etc. Remember, with shoulder dystocia, if you are able to deliver vaginally, then some complications you could expect are Erb's palsy, a clavicular fracture, and sometimes hypoxia or death. If the baby comes out and a few days after it's born and it's presenting with the classic Erb palsy presentation, which is which is basically an arm that's internally rotated with the wrist flexed and elbow extended. This is a Erb's palsy. The parents will usually ask what to do about it, and the correct answer is usually reassure because it tends to self-resolve. And same with the clavicular fracture. There will usually be, crepitus over the clavicle, and the answer there too is to reassure because it will heal on its own. So an important concept to know is fetal bradycardia, how that arises. And there's multiple mechanisms, but one of them is maternal hypotension. So hypotension. So if mom is hypotensive, then she will have reflex vasoconstriction of her spiral arteries, which are the arteries that are attached to her uterus, but this also belongs to her circulatory system. So when you have vasoconstriction of these spiral arteries, that's an attempt to increase total peripheral resistance for mom's circulatory system in order to get her blood pressure up. However, when this happens, this also causes vasoconstriction of the fetal circulation, and that increases the fetal total peripheral resistance big time as well. So this results in reflex fetal bradycardia. So then applying that concept, anything that causes vasoconstriction of the spiral arteries can cause fetal bradycardia. So uterine tetany is one of them. Why? Because it causes vasoconstriction of the spiral arteries. Another one is cord compression. Cord compression basically clamps down the umbilical artery, and that increases TPR as well, which leads to reflex bradycardia. Another important thing to know is fetal heart rate accelerations. This is something that we use in non-stress tests, which is when you are measuring the fetal heart rate over a 20-minute period to see how many times the baby will have accelerations. So adequate accelerations is the rule of 15 and 15, 2 and 20. So 15, increase heart rate by 15 for 15 seconds. That's one acceleration. And if you see two of those in 20 minutes, then that is a good sign. So if you see two of those, it means there's good oxygenation for the baby, and that's a reassuring non-stress test. You do a non-stress test when mom notices decreased movement in the baby. Also, if the non-stress test is basically equivocal or non-conclusive, which means in that 20 minutes you did not see reassuring fetal heart rate accelerations, then you move on to something called a biophysical profile. And that basically is a more extensive version of the non-stress test, which includes breathing, amniotic fluid measurements, tone, movements of the baby, and the non-stress test, and it gets a score out of 10. But basically, if the score is less than 4, then you want to deliver right away. So we were talking about common causes of maternal infection. One of them is endometritis, and this is basically inflammation of the endometrium. We can also call it endomyometritis, which is inflammation of the endometrium and myometrium. Usually this is caused from ascending infection, or it's also commonly associated with C-sections, which is suspected due to contamination. And the signs will be tender uterine fundus, a fever, and foul-smelling lochia. And so lochia is postpartum discharge of the blood, mucus, and tissue. So when you see endometritis, you want to treat that first line with clindamycin and gentamicin. Another common maternal infection is something called chorioamnionitis, which is caused by ascending infection, and it's commonly associated with prolonged rupture of the membranes. Prolonged rupture of the membranes means that there's been 18 hours that have elapsed since the water has broken. And if mom is still in labor for over 18 hours, she's at risk for an infection. How you want to treat that is by ampicillin and gentamicin. So if you see nuchal translucency on a transvaginal ultrasound, that's a sign of Down syndrome or trisomy 18. If you see something that's described as greater than 2 to 2.5 multiples of the median, that's equivalent to saying that there's a neural tube defect. Elevated AFP is usually, I think about things that are associated with like an incompetent body wall in the fetus. It could be either gastroschisis, omphalocele, which is basically abdominal wall defects, or neural tube defects, and through these defects, AFP leaks out. Another common one that can cause elevated AFP, which is actually the most common cause, is underestimation of age. So you'll see an AFP much higher than it should be. That's because the baby is actually older. You think the baby might be 10 weeks, for example, but in reality, it's 13 weeks old. So it's making more AFP than you would expect. Remember, a common buzzwords associated with Down syndrome would be thickened nuchal fold, nuchal translucency, and remember the echogenic bowel, which is caused by duodenal atresia, where you'll see the double bubble sign, which is a very common association with Down syndrome. So yeah, most common abnormal triple screen is wrong dating. So twins have complications as well, and they have a higher rate of preterm delivery, congenital malformations, preeclampsia, and postpartum hemorrhage. Clomiphene is a drug that's used to induce ovulation, and it promotes maturation of multiple follicles, leading to multiple eggs being released. And it's used in PCOS, polycystic ovarian syndrome. How clomiphene works is it's a estrogen receptor antagonist at the level of the hypothalamus. So what this does, it basically blocks the negative feedback. So it tricks the brain into thinking that there's not enough estrogen in the being made by the ovaries. So this stimulates the hypothalamus to release more GnRH, LH, FSH to make more estrogen. And by doing this, this promotes ovulation. Then there's the Kleihauer-Betke test. Remember that this is a test that's used before administering RhoGAM. RhoGAM is basically the antibodies that prevent sensitization versus the Rho antigens found on the fetus in a Rho negative mom. A mom who has, for example, blood type A negative, that negative denotes that she has no Rh antigens on her blood. And as you remember from your step 1 knowledge and your basic sciences knowledge, that whatever you're missing on your own blood, you create antibodies for what you don't have. So if you're blood type O, which means you don't have A, you don't have B, and if you're minus means you don't have Rh, then you'll have antibodies against A, B, and Rh. So if a mom is Rh minus, she will have Rh antibodies that are IgM. They would only switch to IgG if she happens to see antigens that are found in her circulation. So a lot of times in maternal fetal hemorrhage, so like placental abruption, anything that can cause the fetal circulation to mix with mom's circulation, that means the fetus's red blood cells will enter mom's circulation, which means that the baby red blood cells have Rh positive on it. For example, the baby might have gotten it from the Rh positive father, right? If the dad was Rh negative, then there's no way the baby would have had Rh positive. One of the parents has to have it. So if the mom's IgM antibodies see that Rho antigen on the fetal red blood cell, it will type switch to IgG. And that means for the second pregnancy, it'll automatically cross the placenta and destroy any red blood cells that may have Rho positive antigen on the fetal red blood cells, which means the second the younger brother or the younger sister will end up with polyhydramnios due to like massive destruction of the fetal red blood cells. So my point is, the Kleihauer-Betke test, you take a sample of mom's blood and you look at under a slide and they put a substance on the plate which basically tells you what percentage. It eliminates mom's blood, it dissolves it, but basically it tells you what percentage of that blood sample has fetal red blood cells. If it's like 50-50, then you give a certain dose of RhoGAM. If it's like only 10% fetal red blood cells, then you give a lower dose of RhoGAM. And RhoGAM is antibodies that will take out the fetal red blood cells in order to hide it from mom's pre-existing antibodies. So then she doesn't have sensitization. So next is preeclampsia. Preeclampsia is defined as hypertension with proteinuria. So you have to have proteinuria. And how do you define proteinuria? That's a protein to creatinine ratio of greater than 0.3 or greater than 300 milligrams of protein per day. If you have that plus hypertension, which is 1/140/90, this is defined as preeclampsia. Preeclampsia is dangerous because it is associated with a lot of complications such as preterm delivery, placental abruption, fetal hypoxia, etc. But it's also dangerous for the mom in that she can have a lot of complications because she's urinating out so much protein. She's prone to getting edema from third spacing due to decreased intravascular oncotic pressure, and she can get pulmonary edema, etc. And so also the most feared complication is the progression of preeclampsia to preeclampsia with severe features to the most feared one, which is eclampsia. And eclampsia is basically just preeclampsia, which now has gotten so severe that it's caused seizures, and that's called eclampsia. Preeclampsia with severe features is defined as preeclampsia where the blood pressure is over 160/110 or with evidence of end organ damage, whether it's kidney damage, like acute kidney injury, or elevated liver enzymes or encephalopathy. So first line treatment for pulmonary edema would be furosemide, which is a loop diuretic. Another thing is a mom who has herpes simplex virus, you want to give her acyclovir leading up to delivery, and if she's adherent to the acyclovir, then she can deliver vaginally if there are no new genital lesions. However, if she's experiencing prodrome, such as like itchiness or pain or new genital lesions are arising, then she should do a C-section. Next is chancroid, which is caused by Haemophilus ducreyi. And remember, this is one of the few genital ulcers that are painful. The other one would be herpes. And so chancroid will be described as having ragged edges, a necrotic base, and on histology, it has the school of fish description, and then you want to treat it with ceftriaxone and azithromycin. Versus a chancre, which is a painless ulcer, which has a smooth, hard border, and this is caused by syphilis, and you want to treat that with intramuscular penicillin. And remember, it can advance to the second stage, which has the condyloma lata with the Palmer rash, and it can also advance to the tertiary stage, which causes neurosyphilis, tabes dorsalis, syphilic aortitis, encephalitis, etc. And those ones you want to treat that with longer IV penicillin. So risk factors for placental abruption are trauma, previous abruption, hypertension, cocaine, polyhydramnios, because I just think of it as the amniotic sac is so heavy that it can cause detachment, and then cigarette use. And you know, if you think about it, like cocaine, hypertension, cigarette use, these are all associated with decreased arteriolar diameter, and that can cause poor blood flow to the placenta, which makes it weaker, which can cause it to detach. And abruption is one of the types of third trimester bleeding. Remember that it's very painful. The mom will have abdominal pain, a lot of uterine contractions, and vaginal bleeding, but this is painful compared to placenta previa, which is painless bleeding, and that's caused by the abnormal position of the placenta covering the cervical os. When you do a C-section, you're now at increased risk for placenta previa because of that scar tissue. It makes it so that the human body is very smart. It'll notice that that scar tissue is a bad site for placentation due to like the uneven surface. So that causes mom to be at increase for having placenta previa. Also, it increases the risk. Once you have placenta previa, you're also at increased risk for something called placenta increta, placenta accreta, placenta percreta. Placenta increta is the shallowest form, where your placenta basically attaches to the beginning of the myometrium. Placenta accreta, it goes into the myometrium, and then placenta percreta goes all the way through the uterus, and sometimes it might even start invading the bladder, and then this can cause hematuria. If mom has any of these cases of placenta accreta, percreta, increta, which basically means that the placenta is fused to the endometrium, then the only option is to do C-section at delivery, because that placenta won't detach and it'll cause massive postpartum hemorrhage. Next is the big three cutaneous manifestations of pregnancy. The first is intrahepatic cholestasis of pregnancy. This is characterized by really severe itching at night, especially on the palms and soles. There will be elevated liver enzymes due to liver damage, but the key here is elevated systemic bile acid levels. These bile acids or bile salts will deposit on the skin, which causes severe pruritus. So remember, it's very itchy, elevated bile salts, elevated LFTs, and you want to treat this with ursodiol, which basically lowers serum bile acid levels. Next is PUP, which is pruritic urticarial plaques and papules of pregnancy. Mom will, when she's pregnant, will develop stretch marks over her abdomen, but these stretch marks will actually start to get really itchy. She'll also develop plaques and papules, kind of like an eczema, like dermatitis type of presentation over these striae. And then it's very, very itchy, but it's benign, and you treat it with steroids. Next is herpes gestationis, which is basically like bullous pemphigoid of pregnancy. If you remember, you know, like pemphigus vulgaris and bullous pemphigoid is when you have the antibodies, the IgG, that attacks the hemidesmosomes, which are intermediate filaments that anchor cells to the basement membrane. You get antibodies attacking that, and then treatment with this is corticosteroids. And it presents with, you know, vesicles on the abdomen and extremities. Next is acute fatty liver of pregnancy. When you hear this, remember this is an emergency. The baby is at an immediate high risk of death, and you want to deliver right away. So how do you define this? The main thing is like nausea and vomiting, hypoglycemia, elevated liver enzymes. This is caused by mitochondrial dysfunction of breaking down fatty acids. And yeah, you want to deliver this baby immediately. Remember that pregnant women are at increased risk of DVT via compression of the IVC, which leads to stasis, and also due to the increased systemic estrogen, which puts you in a hypercoagulable state. And then if mom develops symptoms of a DVT, which is, one leg bigger than the other that is in a lot of pain, you want to do a venous duplex. But what's dangerous is that a DVT can lead to a pulmonary embolism, a PE. And the main things you want to look for in a PE is abrupt onset of dyspnea, tachycardia, and tachypnea with a low pulse ox or low PaO2. If you have that, then it's most likely a PE. And remember, in a pregnant woman, you don't want to do a CT angio because the radiation is toxic to the baby, so you want to do a VQ scan. Also, to treat a PE, you start with heparin, or you can treat with rivaroxaban. Amniotic fluid embolism is another complication of delivery, and this is when the amniotic fluid gets into the maternal bloodstream through delivery. And this is basically presents like a PE too, but it causes confusion and a rash on the chest. And it's associated with C-section and abruption. And then treatment for this is mainly just supportive. And then remember that amniotic fluid embolism can cause DIC. Anytime someone with preeclampsia has severe features or has progressed to eclampsia, then you want to remember two things. You give magnesium and you deliver right away. And why do you give magnesium? That's because it prevents seizures. And if they have eclampsia, they already have seizures, so you give magnesium as well. But sometimes you have to monitor because it's easier to have toxic magnesium levels. So they tend to ask you, what is the first sign of magnesium toxicity? And that's usually hyporeflexia, and that's the first sign. So yeah, DIC is associated with abruption, preeclampsia, and amniotic fluid embolism. So there's 3 drugs you can give leading up to term, and remember, term is described as the start of week 37. The start of week 42 is considered post-term. If it's before week 32, you want to give magnesium because this helps development of the nervous system of the fetus and it helps prevent cerebral palsy. You give magnesium all the way up to week 32. After that, you don't need to give magnesium anymore. The next thing you want to think about giving for preterm deliveries is tocolytics. So tocolytics can be used up to week 34. Common tocolytics would be like terbutaline, indomethacin, and you want to give this up to week 34 to help delay delivery so the baby can mature more. And then the last one is betamethasone, which is a steroid, and you can give this up to week 37. And the reason why you want to give steroids up to week 37 is to help promote lung maturity. Yeah, so steroids have been proven to minimize the chance of respiratory distress syndrome. So if it's week 32, you want to give magnesium, tocolytics, and steroids. At week 34, tocolytics and steroids. Up to week 37, you give just steroids. After that, you don't need to supplement. So neonatal infections, remember the big 3 bacteria that are associated with infections in babies less than 3 months old, and that's group B strep, E. coli, and listeria. So that spells out BEL, B-E-L, and those are the 3 kind of neonatal infections which are associated with like meningitis. Another mechanism I want to talk about is preterm premature rupture of the membranes. So with preterm premature rupture of the membranes, you'll have leakage of amniotic fluid, which leads to oligohydramnios. When you have oligohydramnios, this basically means that the baby is no longer floating in like a low gravity environment and its weight can compress the umbilical cord. When this compresses, it can cause recurrent variable decelerations, which is what you'll see on the fetal heart rate tracing, where the heart rate of the baby dips down really quick and then comes back up really quickly. Because the normal deceleration is usually the head compression one, is when you have the uterus contracting, then the heart rate will come down and up gradually as a mirror image. Hypoxia is the second one, where it will go down gradually and come back up, but it's late. It's always late after the uterine contraction. And then the last one is recurrent variable decelerations, which is random dips in heart rate that come back up very quickly. It's not gradual, it's very sudden, and this is a sign of cord compression. So if you see the recurrent variable decelerations, you should think that there's cord compression, and what you want to do is reposition the mom so that the baby isn't squishing the umbilical cord, or you want to give amnio infusion. Another mechanism I want to talk about is parvovirus. So parvovirus can present very subtly in the pregnant mother, which presents with arthralgias, malaise, and myalgias. I kind of think of it as very similar sounding to rheumatoid arthritis. She'll have like metacarpal phalangeal joint pain, not feeling well, but it's more transient compared to rheumatoid arthritis, which is more like over the course of months. But adult parvovirus is more like acute onset, the last few days. And so when the mom is affected with parvovirus, this actually attacks the fetal erythrocytes, the reticulocytes, and when it destroys all the fetal reticulocytes, this causes something called aplastic anemia, which shouldn't be confused with aplastic crisis. Aplastic anemia is when you have destruction of all three cell lines, which destroys, platelets, white blood cells, and red blood cells. Aplastic crisis is when you have just decreased red blood cells. When you have decreased red blood cells, then the baby's heart rate will speed up, tachycardia, to try and optimize perfusion to make up for the decreased amount of red blood cells. But what will happen is this will lead to heart failure. And then when it leads to heart failure, that will lead to pulmonary edema and third spacing. And this leads to hydrops fatalis. But remember that also when the red blood cells are being destroyed so much, the liver will try to make up for it by trying to make more red blood cells, but by doing that, it has to compromise and makes less albumin. And when you have less albumin, that has less intravascular oncotic pressure, and that exacerbates even more third spacing. And that's kind of like the mechanism for hydrops fatalis. A sign, what would be a fetal heart rate tracing sign of anemia? That's sinusoidal heart rate pattern, which you see the sine waves. That would be something you would see in a parvovirus infection of the fetus. What would you see in a mother who has lupus? A mother who has lupus is associated in the fetus with a complete heart block. Next is CMV, and CMV is characterized by, I have a mnemonic for cytomegalovirus. So C stands for chorioretinitis, M stands for microcephaly, and V stands for ventricular calcification. And you prevent this by hand washing and not sharing utensils with kids. And that's one of the common perinatal infections. Another one is toxoplasma, which is caused by eating undercooked meats or cysts from cat feces. And this has a triad of cranial calcifications, chorioretinitis, and hydrocephalus. And you treat the mom with spiramycin and the fetus with pyriethymine or sulfadiazine. There's also rubella, and rubella's triad is cataracts, deafness, and cardiac anomalies. Do you remember what the cardiac anomaly is? It's patent ductus arteriosus or pulmonic stenosis. Normal amniotic fluid volume is usually from 5 to 25 centimeters. It's important to know this because sometimes they'll indirectly tell you oligohydramnios or polyhydramnios. So if it's 3 centimeters, then that's oligohydramnios. If it's 30, that's polyhydramnios. So what's another way to diagnose anemia in the fetus other than the fetal heart rate, which would be sinusoidal? Another way is you can do the middle cerebral artery Doppler studies. If you see increased flow, this is anemia. This is a way to also detect it in babies who have sickle cell. Another way to diagnose intrauterine growth restriction, which is defined as size of the fetus below the 10th percentile, is to measure the umbilical artery Doppler. and then reverse flow in the umbilical artery is a bad sign. That's basically saying if there's fetal hypoxia and you want to deliver right away. In the baby who is just born, they're prone to getting conjunctival infections, and you want to cover for chlamydia and gonorrhea. So gonorrhea happens in day 3 to 5, and chlamydia tends to happen on day 7. For gonococcus, that's where you give the erythromycin topical eye drops that prevents gonococcal conjunctivitis. But for chlamydia, it's not effective with topical eye drops. You want to give oral systemic. And that's if you have conjunctivitis on day 7. So an HIV mom can only deliver vaginally if her viral load is less than 1,000 copies of RNA per mil. If it's greater than that, then she has to do a C-section. If a mom has hepatitis B, then you should give hepatitis B antibodies and vaccination at birth. So there's also something called postpartum thyroiditis, which is found in patients who have the same antibodies as Hashimoto's thyroiditis, which is anti-thyroperoxidase and anti-microsomal antibodies. But basically what happens after birth is you get inflammation of the thyroid, which leads to destruction of the gland, and then this basically releases all the preformed thyroid hormone, which causes transient hyperthyroidism. At this point, if you do an iodine uptake, it'll be low. And iodine uptake, they like to test you on this because they want you to know how to conclude certain things based on the iodine studies. And radioactive iodine uptake, if there's a lot of uptake, that's a sign that the thyroid is actively making new thyroid. And if it's not taking anything up, then it means that the thyroid gland isn't making any more new thyroid. So in postpartum thyroiditis, you will be hyperthyroid, but there will be decreased uptake because this hyperthyroidism is caused by an inactive thyroid gland that is leaking out all the preformed thyroid. After that happens, it becomes hypothyroid and then recovers back to euthyroidism. So for example, someone with like Graves' disease, the TSH receptor antibodies are causing you to make so much thyroid hormone all the time. So if you were to give someone with Graves' disease a radioactive iodine uptake, then you'll see diffuse uptake because that iodine is getting sucked up into the thyroid gland, and it's the thyroid making factory, and they're hyperthyroid because they're actively making thyroid. But in postpartum thyroiditis, this is due to inflammation and leakage and not due to active formation. And then you should know about symmetric growth and asymmetric growth. In babies who have intrauterine growth restriction, they can have symmetric growth, which means the head and body are equal size, versus asymmetric growth, which is where the head is really big and then the body is a lot smaller in comparison. And the symmetric ones are caused by chromosomal or like the torch congenital infections like toxoplasma, syphilis, rubella, CMV, herpes. But asymmetric growth is caused by hypoxia, like placental insufficiency, so like hypertension, smoking, poor nutrition. This causes the baby during its development to shunt all the blood supply to the head and favor development of the head over the body as a sacrifice. So remember, asymptomatic bacteriuria in pregnancy is high risk for pyelonephritis. So that's why you do the urine culture in the first trimester, and if it's asymptomatic, you still give prophylactic antibiotics. So the first line UTIs in pregnancy are like amoxicillin, cephalosporin, and nitrofurantoin. But in non-pregnant UTIs, the first line is like TMP, SMX, nitrofurantoin, or fluoroquinolones. But in pregnant people, you can't give TMP SMX because it can cause neural tube defects because it inhibits folate. And you can't give fluoroquinolones because fluoroquinolones hurt the bones and it causes tendinopathies. Yeah, so basically remember the first line drugs for pregnant UTI are amoxicillin, cephalosporins, or nitrofurantoin. Also, you want to know when to give ampicillin prophylaxis for a mom in terms of Group B strep prior to delivery, and usually you give it 4 hours before delivery. The scenarios where you give prophylactic ampicillin or penicillin is if the mom has had a prior pregnancy where a kid has had infection by group B strep, or during this pregnancy she was found to have group B in her urine culture, or if during this pregnancy she's had a UTI, whether it's symptomatic or asymptomatic, then you're gonna give prophylaxis for group B strep no matter what. Or by default too, during weeks 35 to 37, you do a genital culture anyways and an anal culture to check for group B strep. If that's positive, then you're gonna give ampicillin, penicillin prophylaxis 4 hours to delivery as well. If the mom, you don't know her group B strep status because she wasn't following up to her clinic visits, then you give group B strep under 3 conditions. 1 is maternal fever. 2 is prolonged rupture of the membranes, which is greater than 18 hours of rupture of the membranes, which I talked about earlier. And the third is if you don't know her status and she's preterm, then you're gonna give ampicillin or penicillin prophylaxis. Remember, the most common cause of post C-section fever is endomyometritis, and you treat that with gentamicin and clindamycin. Then there are breast abscesses. The main cause is Staph aureus, and this is a red fluctuant is the key word. Fluctuant means that it feels like there's fluid underneath the skin, and you want to treat that with dicloxacillin and incision and drainage. And if it's hard to tell the difference between that and cellulitis, then you want to use the ultrasound. Remember, breastfeeding has all the vitamins except which 2? Vitamin D and vitamin K, so you want to supplement that. You should also know the differences between breast milk and formula milk. Breast milk has 2 proteins, whey and casein, and formula milk also has them, but it has a way higher ratio of casein than breast milk, and casein is a lot more harder to digest, which is why we prefer breast milk exclusively for the first 6 months before giving any food or eating anything else. The baby should be purely dependent on breast milk for the first 6 months because it has a lot of antibodies and lysozymes and protective factors in it, and studies have shown that babies who are breastfed have lower rates of allergies and infections. And also it helps out mom because when mom breastfeeds, she has lower chances of getting breast cancer. Remember that gestational diabetes. So this is another thing too. The prenatal visit, the week 28 visit, and then the week 35 to 37 visit are very important. The first visit, you want to do everything, your standard like CBC, UA, check for all the STDs, HIV. You want to check for rubella, check for blood typing, do a pap smear. But then in week 28, that's when you check for 3 things. Diabetes, you want to do a follow-up CBC to see how anemic she is, if she's like still within range, and then give a RhoGAM shot if she's Rho negative. But this is where you will check for diabetes. And how you do that is you first do the 50-gram glucose load. After 1 hour, if it's greater than 140, then that means she might have diabetes. So you advance to the second stage, which is the glucose tolerance test. You give her 100 grams of glucose this time, and you measure her glucose at hours 1, 2, and 3. If it's greater than 180, 160, 140 at hours 1, 2, and 3, respectively, and 2 out of those 3 are too high, then you diagnose her with gestational diabetes. And then with gestational diabetes, the first line treatment is going to be diet, but then if she doesn't improve her glucose levels with diet, then the second line you want to start is insulin. If you do a fundal height test and you notice that it's incongruent with the baby's age, then the next step you want to do is an ultrasound to see what's happening. That is it for obstetrics, and in the next part we're going to talk about gynecology.